Good afternoon. Actually, as was said, this is meant to be an interactive session. And I have to remind you what was said while introducing me, that I'm not a gynecologist. So please don't embarrass me with gynecological questions or issues.
But embarrass me.
Embarrass her, that's it. Okay. And actually, after reading a little bit, if there is any new material about the topic, how to start HRT and how to stop HRT, I could do this session by presenting one slide and talking for about half a minute. And you will see that this is a little bit theoretical discussion, because by the end of the day, every physician does what he wants to do based on the experience he has and a little bit of reading the literature. But there are no real guidelines or statements or algorithms or whatever you will call it. Actually, it's, let's say, knowledge, experience, and your individual strategy, how to approach the issue of starting HRT and stopping HRT. However, there are some relevant issues that need to be taken into consideration when any physician is thinking, when he's sitting with a woman that comes to ask about hormone therapy. So there are some issues that needs to be considered before making the decision what to prescribe. So let's start, and whenever you wish to interfere, ask something, please. This is not a formal session. Okay. So first of all, of course, as it is right with all decisions that physicians are making, is there a need to prescribe? And the need to prescribe is actually based mainly on the woman who comes to us and tells us how she feels, what are the expectations, what she's looking for. And then, of course, the physician also needs to make his questions to understand better the medical situation. So first of all, define if there is a need. And secondly, if there is a need, of course, we would like to provide the best therapy that is possible. I'm not revealing any new, things, but just to make it clear. And thirdly, we always have to weigh, when we already think about a medication, we have to weigh the benefits, the potential risks, and see whether the individual case scenario fits into the medication that we would like to prescribe. So this is very general, of course. When we talk about hormone therapy, we need to think about the age. It's not the same when a 50-year-old woman comes in or when a 65-year-old woman comes in. And probably all of you know the age factor, which is relevant for HRT, WHI study, and many other trials showed that age matters, because on the one hand, the side effects or the risks are different with different ages. And the benefits may, in some cases, may not be the same if you prescribe to a young, relatively young postmenopausal woman or to an elderly postmenopausal woman. Secondly, the general health needs to be evaluated, and you will see later that we have to refer to certain topics within the general health. And then when we talk about hormones, there is not only one preparation, there are many preparations. If we talk about estrogen, which is the main, let's say, treatment goal, so we have different doses, different preparation, different combinations, mode of treatment, etc. So you need to consider it. And again, in some cases, there is, let's say, an advantage of one type of hormone over another type of hormone. So this, again, should be considered. And by the end of the day, after you made a decision and you talk to the woman and explain everything, the decision is actually by the patient. Whether or not, after hearing what you had to say, if she still wishes to receive the treatment that you are proposing. So let's take just a case, an ordinary case, but I built the case so there are some factors that needs maybe to be considered. So it's a relatively young postmenopausal woman, 52 years old, usually healthy, no medications, and she is entering menopause. She didn't have any period for 6 months, but she has hot flashes. She describes it as severe, day and night, awakes from sleep, so she doesn't sleep well. She's not smoking. She's a bit or more than a bit obese with BMI of 32, with borderline blood pressure, which goes with obesity in many instances. And I don't know what is the higher border for hemoglobin A1C in your country or in your laboratory, but 6 could be considered borderline plus. So it's like the lady probably has some kind of a metabolic syndrome, and when we check the lipids, a little bit of hypertriglyceridemia. The LDL cholesterol, again, not very high, but according to the new standards, it's a little bit higher than what we would like it to be. And some osteopenia, not too much, only the T-score is only minus 1.6, which is okay for the age of 50. So this is the case scenario. And now the physician has to put everything into an equation to see what he should prescribe based on the complaints that this woman wants to get treated. She has a very severe hot flashes day and night, etc. So,
Yes. Sorry.
anyone asked anything? No? Not yet? Okay.
Okay, good.
So the first question is whether we saw that woman the first time in our life. So do we need more information before we make a decision? Anyone could suggest whether we need more tests, more information, anything that might have an impact on the decision? Or this is a really straightforward case and no need for anything else?
Does she exercise? How much does she drink? And what is her family history?
Okay, good. So family history. physical, let's say she's exercising, and also whether or not she drinks alcohol. And this might be important because in many recommendations, or maybe I'm not sure if it's really recommendations, but if we talk about the health condition, it doesn't have to do anything with menopause or hormone therapy. But however, if a person is exercising and drinks alcohol moderately, and you should know that for women, moderately usually means not more than 1 glass per day. For men, you can drink 2 per day. So we are privileged if you like alcohol. So anyway, this is in advantage of your general or usually cardiovascular health. But this lady, she is healthy, doesn't have any cardiovascular complaints, but you're right, it's part of the general inquiry. And family history, of course, it's important. Some people advise, I'm not sure that this is done routinely, but some people advise to calculate a risk score for cardiovascular disease, for stroke, for breast cancer. These risk calculators are very simple and anyone can find them in the internet. You put, let's say, 5, 6 different variables and you get the score. Maybe it's time consuming, I don't know. In Israel, usually you have 5 to 10 minutes, am I right, with a woman? So if you have 5 to 10 minutes for every visit, I mean, if you work for an HMO, not for a private visit, then, and you need, of course, to check the woman also to make a physical checkup. So most of us, they don't put these risk calculators on the table. They just ask the history, the medical history, and if it seems okay, no family history of breast cancer, no smoking, good general health, etc. And of course, the lab tests that I showed you and the weight and things that can be managed quickly. This is usually what it takes, but still, some algorithms ask the physician to use these scores. So I put it here just to remember. And then the question is whether this patient needs a certain formulation. So I'll go back to the description of the case. What do you think out of these markers needs special consideration when you think about hormone therapy? What would you pick as something that needs to be considered?
High triglycerides?
Yes, and you said blood pressure. Okay, but if you said triglycerides, why it needs to be considered?
Well, with an oral preparation, they're going to go higher.
Right, so some, I would say, of the oral preparations may increase, this is a question that I think it's still debated. Some studies, earlier studies show that if you give hormone therapy, no matter, at that time usually it was the Premaryl, the conjugated estrogen, plus MPA, the blood pressure remained the same as in the placebo group. Some people or some studies claim that there might be a little bit of elevation with blood pressure with certain types of hormones, but with triglycerides, it's more evident that oral estrogen, especially the conjugated estrogen, may increase triglycerides. I think you need to know that as a risk factor for women, if you compare them with men, triglycerides are valued higher as a risk factor than in men, while cholesterol, LDL cholesterol, is valued a little bit lower as a risk factor than men. But anyway, since metabolic syndrome is combining weight, triglycerides, cholesterol, blood pressure, etc., so I think we need to consider this metabolic syndrome as a risk factor, and we need then to decide what would be the preparation of estrogen that we will prescribe. I read that some people, and maybe you know better, the Endocrine Society, I think, they prefer transdermal estrogen in these cases. So if there is some risks like triglycerides, blood pressure, overweight, because of the higher cardiovascular risk, they prefer to start with transdermal. But I don't think that other societies, if there are recommendations, they really point at transdermal estrogen as the first step or the drug that you would choose, and not other types of the oral estrogens. What about the bone density? Should be considered. Is it really a problem? Is it another reason to give estrogen if the T-score is minus 1.6 at the femur? This is considered a mild osteopenia. You know that the -1 is the border between normal and osteopenia, so this is mild osteopenia. And I would say that if we were looking at the Z-score of that lady, which means how she compares with the average with women at her age, I would say that maybe 1.6 would be the average, or even a little bit above the average. So I won't consider it as a factor now that needs to be taken into evaluation when we think about the exact hormone to be given. Now, there are other issues that anyone can choose according to his philosophy. Should we start low? Again, NAMS and other societies, the bottom line of prescribing hormones is the lowest possible dose. So should we start low and wait and see how a woman is satisfied with the therapy, and if not, increase it a little bit, or we should start with an average dosage and whatever it is, and if everything goes okay, then it's okay. You don't need to have a stepwise approach that you start very low and you increase it. You have to remember that there is also a practical point here, that if you start very low, some of the women, especially a young woman like we are presenting now, a low dose will not be enough. So she needs to come back after a few weeks or maybe 2-3 months. It's another visit. You need to increase the dosage, wait another 2-3 months. So it's a little bit more time, let's say, consuming. And by the end of the day, no one, as far as I know, and maybe you read some other studies, no one actually, for such a lady, claim that if you start the average or you start the low dose, the adverse effects, I mean the risk, not the simple adverse effects, but the risk for breast cancer or cardiovascular or stroke or whatever we are talking about, the risk is different. So I can't answer it. Maybe anyone would like to elaborate on whether to start low or to start the average dose by your practice. Or maybe I will make a vote. Who starts very low and take a stepwise? Who is doing it? Starts low? Surprising. And who is starting with, let's say, a regular, normal, average dose? So maybe it's 50-50 or 40-60, I didn't count, but it's interesting.
So
What do you
Amos,
say?
I would just like to make a comment with regards to practicalities, and everything you say, whether you start high or low doesn't make a difference to your risks with regards to cardiovascular disease, breast cancer, and so forth. But the thing in this situation is this woman is in early menopause. She's not even 1 year. She is going to have recrudescence of ovarian activity, so her estrogen levels are going to fluctuate. And if you look at the guidelines, actually, from the UK, in the NICE guidelines, they suggest in the late perimenopause and the early menopause that you start low and that you start cyclic therapy. So a low dose of estrogen, whatever, and in this case, I would certainly give transdermal because of the hypertriglyceridemia, and probably because of the blood pressure too, because if you avoid the liver, at least you don't get any extra renin substrate. So she would fit into that start low, and she might even have some bleeding, but the point is that she will have withdrawal bleeding, which is appropriate and won't have breakthrough bleeding. If you start her on continuous combined, especially in the early postmenopause, in my experience, and even what we have with regards to guidelines, are a little bit, they're settled out. Now, if she's 3 years postmenopausal and having all of these symptoms, then you can start, if you wish, the average dose, and you can maybe see her anyway in 3 months, but by that time she's be happy. So in this case, with this particular situation, I would advise you to start low, use the cyclic regimen, but by all means, get a mammogram. Because if she's got dense breasts, which she may have, then that may alter what your progestin is going to be, and definitely cyclic therapy, not that there's a lot of data, is better on the breast than if you do continuous combined. So that's my little comment.
Yeah, very important. You are right. Yes.
I think a further point for starting low, and I agree with everything Elaine said, is also that you're not wanting to lose this woman to HRT, and she will certainly freak out if she feels any sort of breast sensation. And if you start low, the chances that that will happen is less high. And of course, every woman who feels that she has breast thinks she has cancer,
Yes.
right then and there. And then she thinks, oh, these hormones are horrible, they're gonna give me breast cancer. And then we'll see her down the road with vertebral fractures. I also think entering menopause, or she's not even definition menopause, she has menopausal symptoms, with a minus 1.6 already shows that she's starting with suboptimal bones. And so it's really important that we offer her HRT for her symptom as well as for her bones, because that's fairly low for, in my opinion, for her femur.
But you can work it up as time goes on.
Absolutely.
And you remember that the fracture rate with regards to hormonal therapy is what is equivalent to something like 50 micrograms of 17-beta-E2, which is equivalent to CE 0.625. So we know you can maintain bone with the lower doses, but if you want to have fracture efficacy, you need to get up to that 50 microgram dose or equivalent.
Right.
Yes?
My question is, why did she even have a bone density?
Could you speak to the microphone?
Yeah,
Because
please come
other
up to
people-
the mic. All these are important questions.
She
Fina Premji from Calgary. My question was, what was the reason she even had a bone density done at that age of 52 if she has no risk factors?
Sorry, we are not speaking English too well, so we need to speak slowly.
What was the reason she had an initial bone density test done at that age?
Well, you're right, but this is again something that is country specific. I mean, in my country, because the cost of bone density is very, very small, most people that come for evaluation in a menopause clinic or come to a gynecological clinic, they are asked to do a bone density. And since it's given by all the HMOs, and if she's 50, she's not liable by the health basket, the national insurance, but still she has to pay like something like $30 or $40 or something like that. So most women are doing bone density when they enter menopause. But you're right, it's not needed. You can take the score, the FRASC score, if you have it in your country, and you can calculate without the bone density what would be the risk for that particular woman to have a fracture in the next 10 years or so. But you're right, okay.
But I have to tell you, if I had my way, which would be very nice, I would do a baseline bone density in everybody age 50. However, the Osteoporosis Society of Canada does not recommend you do this unless you have ABC risk questions and risk factors, and you can get your bone density at age 65. And then it is certainly covered, but it's covered before. But there are country-specific situations. So your question is good. The theory I like in Israel, I think it would be very nice. And I'm sure it's different in all sorts of countries. And you're giving her counseling, adequate calcium, vitamin D, lots of weight-bearing exercise. So at least you're giving her that information. But the bone density, by true definition, differs in various countries. So we need to get on because we won't finish. Well, we'll get good work, but there's lots of slides.
It's not too long now. Now, we have to remember, of course, the contraindications. So we already said the family history of breast cancer is important because then the individual risk is higher. And then you have to make sure that there's no endometrial problems, bleeding, irregular bleedings that might be contraindications, thromboembolism. Everything is written in the label, actually. And of course, if there is a history of thrombophilia, familial history, etc., etc. If we talk about endometrial protection, which is needed when you are considering hormone therapy to a woman with a uterus, then another question comes to our mind. What would be the best way to protect the endometrium? Should we use continuous therapy when you are combining progesterone? Of course, you need to give progesterone, or you can use sequential treatment. Now there is a possibility to give estrogen instead of progesterone to give a serum combined, so it, again, in order to protect the endometrium. And there are other ways, local, let's say, progesterone, that would protect the endometrium. I'm not sure that this is available everywhere, but anyway, it is possible. And another product in some countries very popular, in other countries not so popular, the Tibolone. And the Tibolone, as you know, is having both estrogenic and an effect on the endometrium, so you don't need to take progesterone. So Tibolone, which is now generic, is also a potential option. Yes.
I've, until this conference, never really considered vaginal progesterone. Could you comment on dose and evidence for efficacy of vaginal progesterone?
For you.
So, really, not too many people use vaginal progesterone because you can only get it compounded, but you can use natural micronized progesterone, which we call prometrium, and it comes in 100 milligrams. That can be taken orally and it can be taken vaginally, but that is the only one that is absorbed to the same amount. So if you are looking at efficacy and you are looking at side effects, prometrium, natural progesterone, is soporific. It makes you sleepy. 100 milligrams is wonderful. 200, sometimes you get sleepy. And 300 milligrams is a little bit much. So what you must remember, if you're using natural progesterone, that 300 milligrams of prometrium is equivalent to 10 milligrams of NPA. 200 milligrams is equal to 5 milligrams of MPA, and 100 milligrams is equal to 2.5 of MPA. So you want to protect your endometrium accordingly. So that's the only thing that you can give. Now, in the uterus, we don't have data that supports this is a good thing to do, but we as gynecologists love to put something inside the uterus because then we convert this to unopposed estrogen. But a Mirena, 52 milligrams, is a huge dose for a postmenopausal woman. And there are no data, although there are some studies that show that it is efficacious, but it's a huge amount of progesterone to the smaller amount of estrogen. The smaller intrauterine systems, there's something in Canada, and I don't know if it's available, there is something called a Kylina, and there is also another one. So there's 22 and 14 milligrams. So many of us off-label will put a smaller 14 milligram intrauterine system in so that you can then give estrogen. So your question is good, but we are still looking for the ideal intrauterine contraception, which is not yet available. And people have been looking at this for the last 20 years.
Okay, so let's move on for the sake of time. And I would like to mention 2 points. One is that I think that there is a clear agreement that if a woman the main symptoms are vaginal, she can be prescribed a vaginal treatment, let's say, vaginal medication, whatever it is. And but vaginal medications for vaginal symptoms probably will not have too much effect on the systemic symptoms like hot flashes, sleep, etc., etc. Secondly, just to go back, we were talking about low dose, normal, average dose. No one said what is today considered a normal dose, what is today considered start low. So maybe you could just, if you quote a little bit of dosages, what is normal, what is low, ultra low?
So it definitely depends upon the time of the menopause. So if you have a little bit of estrogenic activity, you need more progesterone. So if you are giving low dose, so something like oral estrogen, 17-beta-E2, 1 milligram, usually an average dose of MPA, 5 milligrams will work, and even 2.5 every single day. If you are obese or you have an obese patient, they will often need a little bit more. And you've got, in some countries, really different things. We have natural micronized progesterone, and I've just given you what there is. We have MPA, 2.5, 5, and 10. We do have norethindrone in a birth control pill, and it's 0.35, and 2 of those tablets equal 10 milligrams. And we also don't have things like levonorgestrel alone, but some company or some places do. So if you're doing higher doses of estrogen, you need higher doses of progesterone, and you need more cyclically. So continuous combined, you may be able to get by with 2.5 every day. Whereas if you're giving that same woman cyclic, you may need 5 to 10 from day 1 to 12 or 14, because what you want to do is convert the endometrium to a safe, even minimally proliferative, but the only way you can convert to a secretory endometrium is to give higher doses, and that produces bleeding if it's cyclic. So there's many of these things that you have to consider.
Okay, any questions? So I think I'll skip a few slides and we'll go to the other to the other issue, how to stop. So again, there is a case, a 63-year-old woman. She takes HRT for 11 years. She feels okay, no symptoms, but she comes to you and says, as many come and say, I'm afraid, I read about breast cancer, friends tell me, etc., etc. I want to stop. And again, these are her, some of her, the values that are maybe important. And here I put a femur T-score, which is minus 2.4, which is actually borderline for osteoporosis. But she's 63 years old. So again, let's say the general question is, should such a lady stop? Is it correct? Is it worthwhile? Is it safe? And when should a lady stop taking hormones? Of course, if this lady told the physician that she feels well, no problems, she sleeps well, no hot flashes, no nothing, she feels well. So again, this is a discussion between the patient and the physician, and I believe that the physician should tell the lady a few major points. First point is that when you stop treatment, in about half of the cases, nothing will happen, or almost nothing will happen, and life goes on as it was before. She feels well, and there's nothing more to do if we talk about symptoms. But in half of the cases, the symptoms may return, sometimes very serious symptoms. So a woman should know that there might be recurrence of the symptoms which might need treatment, maybe other treatments, but might need treatment. And secondly, it's very important, especially in this case, that once hormone therapy is stopped, usually the bone density goes lower quite quickly. Within a year or two, we should see a lowering of the bone density, because the protective effect of estrogen is there only while treated. With other osteoporosis therapies like bisphosphonates, if you stop the therapy, there is still a protection for a year or 2 years. And this is why with bisphosphonates, we usually do what we call a drug holiday. But with hormones, once you stop, you should expect some worsening of the bone density. And if she starts with a minus 2.4, so she is borderline osteoporotic, and she needs to be evaluated more closely and perhaps take another form of therapy for osteoporosis. So these should be the points for discussion. And let's say after the discussion, there might be a compromise with the patient, like, well, maybe you go on with very low estrogen. And again, you will elaborate on it in a minute. But so let's say, again, we are not sure that we are reducing the risk, but probably if someone is taking a very low estrogen dosage, the risk for some problems would be lower. Secondly, the question is, and this is a very important question, whether we stop it abruptly or we taper down the dosage for a certain period of time, hoping that if you do it, maybe the recurrence of symptoms would be less. I have to say that no one has a proof that either way makes a difference. But still, some physicians feel more comfortable to reduce every few weeks, to reduce a little bit the dosage, hoping that this would help. But studies are not too big or double-blind in a way, or so we can't get any real help by the studies that are published, and everyone is doing whatever he feels like doing it. Please.
So with regards to this, Amos is quite right, but patients like to feel that they are in control. And to them, it makes sense with looking at SSRIs and many other medications. They like to taper down, whether they take a tablet every other day or whether they cut the patch or trim the patch, and they can elongate the period. So if you want to come off, never come off in the summer when it's hot in Canada. In Australia, it may be quite different. And so when the patient is comfortable doing what she's doing, and there's a little bit of guidance for her, so you just don't tell her to stop, but you give her that option and tell her, you know, there are some people that stop and they do fine. So this is a patient-oriented situation. And I totally agree. Once you have stopped hormones, you need a bone density at least 1 to 2 years, at least 2 years afterwards, because actually there can be a rapid bone loss after you stop hormones, and then you need to think about doing something else. But you need to make sure, as a consultant, you put this in your letter, and you make sure your patient knows, because the patient these days is in charge of her own health.
Yeah, and I didn't mention it, but estrogen, estradiol, and other types of estrogen reduce the LDL cholesterol. So once you stop giving the estrogen, you should also monitor the lipid level. Maybe the triglycerides would go a little bit lower, but the LDL cholesterol might go higher. So this again should be monitored.
So I'm also going to talk about how to start and stop hormonal therapy. And these are my disclosures. And I'm trying to be pretty evidence-based, but you can't always practice evidence-based medicine. You have to practice by the seat of your pants, you have to practice by what experiences you've had, and how much compliance you're having with the patient. But above all, we will do no harm. So individual decisions are very important. Just read this slide if you can, because I don't need to talk about this too much, but definitely quality of life, the woman's health priorities, what she should be doing, and then looking at her personal risk factors. I feel very, very strongly about doing a risk assessment on a patient. And I have developed for our menopause clinic just a one-page risk assessment, and we all carry highlighters around. Red for danger, and blue for be careful, yellow for a little bit of trouble, and absolutely nothing when you're average. So when you do the major factors, and we're talking about osteoporosis, cardiovascular disease, stroke, and the cancers, breast, colon, and for gynecologists, we're talking about cancers as well. And you may have to slip this into another visit, but it's important. So the global consensus statement on menopause and hormone therapy in 2016 puts, believe it, all of this into some pretty concise guidelines, and I strongly recommend, and this is a conglomerate across the globe. And it was a revised guideline in 2016, because our first one was 2013. And if you look on this slide, it has been endorsed throughout the world. So it's only 2 pages, so very easy to read. So again, a little bit of slide, individualizing care, lots of touchy-feely stuff. You need to be sensitive to other factors and discuss the benefits and risks, but I won't go through that because I do have some other information to give you. So this slide kind of expands on what was said by Amos. And if you look here, you can see that there are distinct physiologic differences due to the first pass mechanism. So what's the difference between oral and transdermal? So if you look at oral estrogen on the one side, transdermal on the other side. So if you bypass the liver, you don't stimulate clotting factors. No change with transdermal. If you are looking at cholesterol, the big issue is an increase in triglycerides, up to 35% with oral, but definitely increased. So what do diabetic patients have? They have hypertriglyceridemia. So right away you can say, you know what? If patients have problems with impending glucose issues, or if they're diabetic, you don't have to worry about them becoming worse, but you do have to not put them on oral estrogen, I feel, although that's not 100%. I think transdermal is the key. So triglycerides are important. HDL is increased with oral estrogen, which is very good. Now, it's not decreased with transdermal, but you don't get that good HDL support. LDL goes nicely down with oral, but not, it's neutral. The one area that I would like to bring to your attention is CRP. Now, you want to look at high-sensitive CRP, which is C-reactive protein. It can be elevated by as much as 85% with oral estrogen. And the last thing you want, if anybody has cardiovascular disease risks or diabetes, is an elevated CRP with inflammation. So that's important to know. And of course, sex hormone binding globulin goes up with oral hormones, and definitely thyroid binding globulin goes up, so you need to look at that. But it's wise to do a lipid profile, and I certainly do that before, or I get the information from the family doctor. So estrogen's effects differ by route. The best evidence of this is regarding venous thromboembolism and stroke. And in the United Kingdom, family doctor GP research study, in their cohort reported by Renault in 2010, in 7 years, they showed that there was no increased risk of stroke among transdermal estrogen users, but a small increased risk, relative risk of 1.28 with oral. And that's a huge number. Don't have time to show you all the numbers. And in a smaller study, which looked mainly at VTE, but these were patients that just had VTE, so the numbers are small, so we can't do an E3N French cohort with 80,000 patients, but they did show that oral users had an odds ratio of 3.5 for VTE overall. Now, there's a lot of criticism about this because it's not a randomized controlled trial, but it is specific to oral and transdermal estrogen when the relative risk of or odds ratio is 0.9. I do have the E3N cohort here. Well, actually, I don't. Let's just skip that slide. So here is the E3N cohort and postmenopausal hormone therapy and the risk of VTE. And if you look, you can see that the current use of the norpregnane derivatives, and that is in which medroxyprogesterone acetate falls, according to the ratio tree, it is increased. And the others are not too bad. And the E3N trial was 80,000 French women over 7 to 10 years. But again, they didn't really look at all of the estrogens. But it's a large trial, and they had a lot of diabetics in that trial. If you look at oral and transdermal estrogen and risk of stroke, in that red box, you can see that dosage matters. So when you had low dose estrogen, very low dose, and low dose transdermal, it fell on the right side of the odds ratio tree. With high dose transdermal estrogen or regular oral estrogen, you found an increased risk in all of those areas that are in that red box. So yes, low dose was better, but high dose, which is 75 microgram patch, 100 microgram patch or equivalent, does increase your risk. So with transdermal, if you're concerned about that, and the average dose is anywhere from 25, 37.5, or sorry, the average is 50 and then a lower 37 to 25. And the estrogen effects also depend on age, and I don't have time to go through the KEEP study, but in this study, which looked at transdermal versus oral with cyclic micronized progesterone from day 1 to 12, both oral and transdermal seem to show excellent cardiovascular data. But now, this is a randomized controlled trial. It's about 875 patients. And the ELITE trial, which is we waited for a long time, a very elegant trial, looked at the early initiation of hormones. So they looked at oral 17-beta-E2, 1 milligram, with a transvaginal progesterone that is used twice a week in fertility patients, which protects the endometrium, again cyclic from day 1 to 12. And they found that the earlier women that were close to the menopause did not have any progression after 6 years, but they found that the late starters did have or calcification scores that suggested as markers that there was an increased risk if you delay. But the guidelines say that if you take hormones within the first 10 years, you certainly are still in a very safe group. So that's all I'm going to show you. And I'll skip this slide because you all know it. But here on the left-hand side, premenopausally, you can see the clear flow of blood with no atherosclerosis. Then in the menopausal, late perimenopausal years, where we give hormones, you're starting to get a little bit of lipid-laden vessel walls. And then, of course, after age 60, on the one side of the slide, you can get atherogenic plaques, which can be loosened, and your estrogen then is not protective. So, but you know that. So one slide only on local vaginal estrogen, and I tell you that some of these low doses, which we're becoming very comfortable with, not enough for the vagina. And so unless you sometimes ask and say, you know, I know your flushes are better, but how is the vagina? Is it dry? Is it moist? Are you having any problems with dyspareunia? Because you often have to add something even to an average dose estrogen. And you've been to the luncheon symposium. And you need to consider this, even for women, of course, that aren't taking in hormones. You do not need any concomitant progesterone if you are taking estrogen alone. And they talked about, still it has the black box warning, which is a pain. So why do we use progestins? Well, we use it for one reason only, and that's to protect the endometrium. And we use it for women with an intact uterus. When you add progestin or progesterone to estrogen, you do get a little bit more efficacy. You do get a little bit of decrease in flushes, and that has been shown. So the additive effect may fit into your practice, but you're not going to do that if the patient has had a hysterectomy. And progestin effects differ by regimen. And we talked about cyclically, we talked about continuous combined. Didn't talk about the regimen that they use in France. They use continuous combined cyclic. So 1 to 25 continuous combined, and then you get a breast break. And people are very comfortable for that. So for breast cancer concerns, and if you have dense breasts, especially extremely dense breasts, you want to use the cyclic regimen. And it may lead to, number one, a little bit of 2 weeks of a breast break, but less breast density, and that was shown with the PEPI trial. And in a large Danish cohort by Tomi Mikkola and his group, the heart attack risk was increased only in the continuous HT users, which is interesting. We didn't find that with WHI, but there were different regimens, and there was no increased risk with estrogen alone or cyclic EPT. So these are the regimens. So you've got estrogen alone, you've got estrogen with progestin cyclically. The longer you give the progestin, the better it is. So 1 to 14 is what I prefer, but in some patients I give it 1 to 16 as well. And if I have somebody who really has gotten a little bit of a thickened endometrium, I will even give it 1 to 18 for a couple of months. And then you can see the continuous combined. And then, I don't know if some of you were in the transdermal session this morning, but Dr. Wendy Wolfman mentioned a unique regimen from Canada, which has never caught on. So that's giving estrogen every day and giving progesterone every 2 days. And so that affects the estrogen receptors and continues to give you amenorrhea. So that's something that you can think about. And then I talked about the French regimen, which has never been really written up. So what about cyclic or continuous HT? Well, we've got British Menopause Society guidelines for this, and I mentioned that. If the last menstrual period occurred 1 year prior to starting hormonal therapy, they suggest a sequential combined regimen so that any extra estrogen can be controlled by a slightly larger dose of progesterone. After greater than a year, or maybe even a little bit longer, because estrogen continues to be put out by those pesky ovaries sometimes for 2 or 3 years. And they may look tiny and atrophic, but you get one little follicle, and then you've got a postmenopausal bleed, which you will investigate with a vaginal ultrasound and endometrial biopsy, and everybody will be happy at when it's negative. So the continuous combined is the most favorite, but maybe not the best physiologically. If you have increased breast density, consider the cyclic therapy because you need that breast break. And I find that mastalgia, just like the lady said, patients get mastalgia and they're petrified about breast cancer. So progestins and progesterone are different. So in the case of breast cancer risk, there is evidence that micronized progesterone, and what we don't have in North America is dydrogesterone, are associated with lower breast cancer risks than other progestins, especially the norepregnanes, the MPA. So in, again, this very large E3N cohort, with a relative risk of 1, which is no increased risk, with micronized progesterone, looking at what the numbers were with other progestins, and mainly these are the 19 steroids, the relative risk was 1.69. So again, when you're starting hormones, you've got to have that mammogram so you know what the breast density is. And normal mammogram does not cut it. MPA increases breast cell proliferation, whereas, interestingly, and I'll show you in a minute, micronized progesterone does not. So the opposing effects of MPA and micronized progesterone on breast tissue are related to some of the non-specific effects of MPA, including glucocorticoid activity and differences in the regulation in gene expression. So look at this, the steroid effects on breast cell proliferation, which was done in human breast tissue, looked at in biopsy tissues at baseline. So in the top panels, we've had baseline, no hormones, and after 2 months of oral CEE and MPA 2.5, look at the increased proliferation in the breast tissue. Baseline, the bottom panel, after 2 months of transdermal estrogen and oral medroxyprogesterone acetate, again 200 milligrams from day 1 to 14 because you need 200 if you're giving the cyclic therapy. There certainly is a big difference. So when I saw this at one of the menopause conferences, I went and talked to the person who was giving the talk, and I said, I want to put that in my slide deck, and I show it to all my residents. And it's not the last effort, but you know, we are very concerned, to say nothing of our patients, with regards to breast cancer. So when do you consider giving transdermal estrogen? So I'm just going to put these all down there. So oral is wonderful, but in Amos's first patient, I think transdermal was warranted. So she had an underlying medical condition. She was obese, she had mild hypertension, she had hypertriglyceridemia. Didn't have gallbladder disease, but certainly missing that pass through the liver on the first go is a good thing for her. And there's a steady state with estrogen that is given in transdermal form. So we have patients who have had PMS. So when that occurs, they can get PMS with even the best progestin, or they've had menstrual migraines. And definitely patients who do shift work do much better when they are taking a steady state. And a steady state can only be reached by giving estrogen in a transdermal form. Because if you give oral estrogen, you get at seesaw, sawtooth, so you get a higher level and then a lower level, and of course this can increase headaches. Inability to use oral tablets, so any problems with stomach and gallbladder and stone. For smokers, as some of you have heard, I do have a slide on that. And for patients, choice. If they say, and even if they do say, you know, my next door neighbor has a patch and she loves it, and maybe I would love it too. And so we talk about the choices, but it's there. So why avoid oral estrogen in smokers? And then the bottom line is that when you smoke, you increase the clearance of estrogen, and you need higher doses of estrogen in order to get the same efficacy. To say nothing about the fact that estrogen causes increase in vasomotor symptoms and increased symptoms of GSM. So for any smokers, I certainly think transdermal is good. So what new HT formulations are available? How many of you went to the Duovive Luncheon Symposium yesterday? Not many, and they had lunch. So a TSEC is a tissue-selective estrogen complex. And what this is very unique. It combines conjugated equine estrogen at a lower dose, 0.45 milligrams, with 20 milligrams of a SERM, selective estrogen receptor modulator, and this is basodoxifin. Now, we're used to SERMs. We're used to tamoxifen. Certainly in the United States, raloxifene is still used, and in Canada, for osteoporosis prevention and treatment, although it is wonderful in the spine, but doesn't protect the hip against fractures. So we are used to SERMs. Raloxifene or Vista didn't really catch on very much, but people would say, oh, well, I'll make my own SERM and my own TSEC, but they worked very hard at the pharmaceutical company, and the best combination was CEE at 0.45 and 0.625, and the wonderful data in the SMART trials of 5,000 patients, and they found some very important things. So this is one patient who I would suggest should have a tissue-selective agent, a TSEC. So this is Mrs. IP. And Mrs. IP is intolerant to progestins or progesterone. She's a 54-year-old G0, P0, nulla gravida patient with disruptive vasomotor symptoms at work during the day, and it keeps her from sleeping. She couldn't take the birth control pill because of its progestin dominance, and she had all kinds of PMS. She has a uterus. We don't know about postpartum depression because she never had a baby. She was started on 17-beta-E2 1 milligram and MPA 2.5, unable to tolerate that. She was switched to natural progesterone in a continuous combined session using 100 milligrams of micronized progesterone. She feels horrible on the progesterone, dizzy, depressed, unwell. They used it vaginally, because vaginally you can decrease the symptoms of progestin excess. Even though it wasn't progestin excess, she was still depressed and had headache. She tried another progestin, which is norethindrone, and norethindrone in Canada, and they have it in the United States, is a birth control pill, progestin only, 35 micrograms. And so they tried that, and that didn't work. So what are the options for an intolerant progestin patient? Well, if you listen to Steve Goldstein and you've got an ultrasound in your cabinet, you can do regular ultrasounds and give unopposed estrogen. I don't do this. Mind you, maybe if you're taking very low doses, you could give unopposed estrogen, but you've got to monitor the endometrium. You can try long cycle hormonal therapy, and you notice I don't talk about HRT anymore. We're trying to switch everybody to using menopause hormonal therapy. I don't think it'll ever happen because everybody calls it HRT. And that is fraught with difficulty, but even if you give Provera or medroxyprogesterone acetate, you then have to give every 3 months a 10 milligram dose, and the patient will go cuckoo with that, but you can try. You can switch to the vaginal route, didn't work for her. You can try a Mirena intrauterine system. However, there is for some patients, and especially for these kinds of patients, enough absorption that they can feel their PMSy symptoms. Well, what about the new TSEC? And that's exactly what we did. We stopped her hormones. We tried alternative therapies. Oh, well, before we did that, we tried the SSRIs and gabapentin and clomidine. And of course, this wasn't enough for her hot flushes. So we're thinking about the TSEC here. So just one slide to give you a little bit of physiology. With basodoxifene, 20 milligrams, CEE, 0.45 milligrams, you get a wonderful reduction for quality of life in hot flushes, and the severity decreases by 54%. And you get good activity in this, and good control of vasomotor symptoms right away within 1 month. You do get good bone support, because remember, some SERMs and all SERMs are good for the bone, like raloxifene. So the basodoxifene is agonistic and stimulates good bone. Endometrial hyperplasia, less than 1%. When women take this, they have no bleeding. Happiness it's equivalent to continuous combined. So the amenorrhea rate in the SMART trials, similar to placebo, and certainly much lower than the continuous combined CEE and PA. There are good effects on the vagina, so you get increased superficial cells, reduced parabasal cells, the vaginal pH goes down, so it becomes more acidic. Of course, vaginal health improves with decreased dyspareunia, and even the sexual domain, and it was measured by the MENQUAL, seemed to improve and was statistically significant, although I don't think that this was very robust. And there was an improvement in sleep and quality of life. Now, I apologize because this is all I have, and I want to end up a little bit with talking about duration of MHT, because we don't know exactly what to do. How long should it be? What do we do if patients have resurgence of symptoms? So the dose and duration of HT should be consistent. Oh, excuse me, my children. You have to be a mother. No, there must be some emergency, but it can wait. So dose and duration of HT should be consistent with treatment goals and safety issues and should be individualized after reviewing benefits and risks. This is what is stated in the goals of all of the guidelines. The impact of hormone therapy on breast cancer risk is small, so they're trying to be reassuring, but does increase with longer exposure, especially to estrogen and progestin combinations. When hormone therapy is stopped, all the benefits that we talked about, bone, arteries, GSM, are lost. So what about this long duration of hormonal therapy? What does it benefit? Well, certainly hot flushes and urogenital atrophy, but you can get away if it's just urogenital atrophy with local treatment. Definitely in this patient, prevention of osteoporosis and fractures, but remember, bone density will be maintained even with lower doses of estrogen, but there's no fracture prevention. So there may be, in some women, a reason to continue hormones even if she's over 60 and over 10 years on hormonal therapy. Vasomotor symptoms, as Amos said, will recur in 50% of women stopping hormones, which is wonderful. You tell your patient, throw the dice and see which group you're in. And after hormonal therapy, all women will lose bone, and we talked about that. Women who initiate hormone therapy when older than age 60, and we don't do this much because of the dementia data, or who are more than 10 years from their menopause, are at higher absolute risk of coronary heart disease, VTE, and stroke. And if you initiate it according to WHI after age 65, it increases the risk of dementia. So if we look at the long duration of menopause hormonal therapy and look at the extended effects after the WHI, and this is Dr. Manson and her group, and we're talking about 13 years post-stopping hormones, breast cancer risk with the continuous combined remained elevated post-follow-up, and the hazard ratio is 1.29. The breast cancer risk in CEE alone, however, was reduced at the 6.6 year post-follow-up, and that hazard ratio was improved. So as we know, estrogen alone and its conjugated estrogen, which may have SERM-like possibilities, and that's what Steve Goldstein thinks, has not been proven. So can you get this with 17-beta-E2? I don't know. Cardiovascular mortality was neutral post-stopping at all ages after 13 years. All-cause mortality was neutral after 13 years. Follow-up with CEE and MPA, and that was neutral at a hazard ratio of 1.01. Hip fracture risk reduction, and this is despite the rapid bone loss that occurs after stopping, persisted 13 years post-follow-up with a hazard ratio of 0.31. So I find this difficult. On one hand, I'm saying be careful if you stop hormones, you're going to get rapid bone loss, and I've got the slides to show for that. And on the other fact, Dr. Manson has got the studies that show that post-stopping, you still have protection. Now, these are patients from WHI, so diet, exercise, calcium is probably taking an effect here. And endometrial cancer risk reduction is possible in this group after 13 years after stopping at 0.67. So what can we then say about long duration MHT? It does not need to be routinely discontinued in women older than age 60 or 65. And we are looking mainly at vasomotor symptoms, quality of life, but there are some women that get depressed. And the SSRIs, SNRIs don't help. The only thing that helps is estrogen. Memory and cognition in some patients makes a difference. And of course, you can have osteoporosis prevention and fracture prevention. So you may continue MHT beyond age 65, and the North American Menopause Society has a nice little fact sheet that you can give to your patients, and they can take it, or you can send to your referring physician. And if they're going to stay on this hormones, you want to get them to the lowest dose that you can, and you want to do annual reevaluation. And there is some suggestion by some people that when you are at this age, probably transdermal hormones may be better. So this is a time to consider switching from the oral, if they're on this, to transdermal. And there's a nice article written by Andrew Konitz from the North American Menopause Society, who has conjectured that at this age, it is possibly safer, and maybe you can take it forever. We don't know. We have no studies. So periodic trials of lowering or stopping hormones. So you say to your patient, maybe every 18 months when it's cool and you're not stressed and everything in your life is wonderful, you can go off the hormones for a month or two. And they'll come back and say, oh my God, it's not any better. And, oh, it's not so bad. So at least you are doing what is recommended. And changing to the lower, safer dose of transdermal, good idea. The patient feels she is doing something. And we don't have long-term duration on vaginal estrogen, but it would appear that we can take it forever. But be careful of the cream, because 0.5 grams 2 or 3 times a week is okay. If the patient discovers she uses 1, 2, 3 grams in the vagina, she can control her hot flushes. So this is my last slide. The consensus opinion, looking at all of the various guideline areas that I've put together on MHT, menopause hormonal therapy in 2018, is choose the most effective dose for symptom relief, no study done on duration of therapy, no increased risk of breast cancer up to 4 years, discontinue when symptoms are gone. Well, how do you know that? When you're taking hormones, your symptoms are gone. And continue with close monitoring if longer duration is going to be done. Route of delivery, well, we've discussed that. Age of initiation time since the menopause is good. So if you started hormones at age 51 and had your last period at age 50, maybe you're a safer person for longer duration than if you started it 3 to 5 years after, even though that's within the 10 years. So again, you've got to use your clinical judgment. And breast cancer risk does not increase appreciably with short-term use, as you all know. And individualization is the key. The patient-doctor relationship is wonderful. And if you want a compliant patient, you need to spend a little bit of time. So I thank you very much for your attention.